Okay, so welcome. Dr. Vora just arrived. Hello, Dr. Vora. We're so glad you're here. Let me make you co-host, and then we are going to get started with the Pet for You Education Hour with Dr. Vora. Are you ready to share your slides? I made you co-host. Dr. Vora, can you just get your slide share so we
Yeah, let me pull it up here.
Okay, just so you know, we have this recorded, so everyone knows that. We want to welcome you all. It looks like we have about 31 people on the call. Thank you. We're really excited to have so many.
Let's see.
And while we're waiting for him to pull up the slides, I'm going to do a little shameless plug for our fall in, no, which one is this? Fall in
Bring
to
into
winter?
summer.
Spring into summer. Okay. Spring into summer. One of our fundraising events, we're trying to raise $10,000 by Labor Day. So if you haven't had an opportunity to give, we would love, any amount that you can share with us on our website. That would be awesome. Okay, you're on. We see your screen. We see your slides, Dr. Vora.
Sounds good. Let me just pull up the slideshow. Can you all hear me?
Yes, we can.
Very good. Well,
Okay, Dr. Vora, I think you need to switch views. You're on presenter view. If you could swap screens.
I'm sorry.
We're seeing your presenter view. Do you want
Oh,
to switch it to
yeah, let me.
just swap screens or switch?
Sorry, bear with me here.
No worries. While you're working on that, I'm just going to also let everyone know that we have a couple new classes that are going to be starting. So look at the website. One is another speaking class, one to work on the Speak Out, using the Speak Out program, and then another exercise class. So please definitely check out the website and the newsletter that is amazing that goes out. So check your emails for that information. That's perfect. You're all good to go, Dr. Vora. Thank you so much. And we want to thank you. Dr. Vora, let me give I'm going to let him introduce himself, but Dr. Vora is a movement disorder specialist, and he happens to also be on our board of directors as our medical liaison, and is going to speak today on autonomic symptoms of Parkinson's disease. And I'm going to let you introduce yourself further, Dr. Vora. So please take the floor.
Thank you so much, Trisha. No, yeah, as Trisha mentioned, I'm one of the movement disorders neurologists out here at Mission, over with Mission Heritage Medical Group at Mission Viejo. I did my training out in Phoenix at the Mullen Hawley Parkinson Center, and then returned back home to practice back in 2018. So I've been out here for 7 years now. Looks like someone's trying to join here. Trisha, do everyone that I think you already took care of it there.
Yeah, I'll take care of all the admits. Don't worry about it.
Well, we'll go ahead and get started, or do you want me to wait until everyone's joined in?
Go ahead and get started. That's fine. Don't worry about it.
Let's see. Well, I just wanted to quickly review the idiopathophysiciology of Parkinson's disease, just go over briefly what, how do we diagnose Parkinson's, what causes Parkinson's, what are the symptom manifestations of Parkinson's, both the physical or what we call motor symptom manifestations of Parkinson's, as well as the non-motor or non-physical symptom manifestations of Parkinson's. And then we'll get to the crux of our talk today, which is on the common autonomic symptoms, which is a subset of the non-motor symptoms of Parkinson's disease. And both Tricia and I will comment on some of the treatments that are available for some of these autonomic manifestations. But just a little brief history about Parkinson's disease and how it came to be diagnosed and described. It was first described by James Parkinson in his essay on the shaking palsy, and that was back in 1817 or so. And then during the 1900s, we kind of learned a little bit more about what is the pathology of Parkinson's. In 1912, Frederick Louis described like these little inclusion bodies that are found under the microscope in patients with Parkinson's disease, and those are what are called Lewy bodies that bear his name now. In 1919, there was a physician, a researcher by the name of Tretyakov, who observed that there was loss of neurons, particularly in the substantia nigra of the midbrain. So those are what we call the pigmented neurons in the substantia nigra of the brainstem there. And later on, we would learn to learn that those are implicated in the dopamine pathway of the brain. In the 50s, we learned more about the importance of the dopamine in terms of being able to regulate motor circuitry and movements that we don't think about. And we learn more about the pathways of the motor circuitry in the brain and the role of dopamine there, and how depletion of dopamine affects those and causes the symptoms that we see in Parkinson's. And then it was in the 1960s where uh, uh, basically revolutionized the treatment of Parkinson's using levodopa, which gets converted to dopamine in the brain to treat dopamine deficiency, namely Parkinson's disease. So why are we learning about Parkinson's? Obviously, this organization is, dedicated to Parkinson's, and why is that? It's the second most common neurodegenerative disease after Alzheimer's dementia, and the absolute numbers are growing as the population ages. So worldwide prevalence is about 10 million, about 1 million in North America alone. And every year there's about 90,000 new cases that are diagnosed on an annual basis. The incidence, mostly it's a disorder of aging. There's a few subset of the total patient population of those affected with Parkinson's that have genetic form, but the vast majority have sporadic form of the disease, mostly thought to be due to age. So the incidence of Parkinson's increases with age. About 1% of people age 60 and older develop Parkinson's, and about 5% of people age 80 and older develop Parkinson's. A little bit higher incidence in males than females, at about a 3-to-2 ratio. And risk factors, as I mentioned, are age, and also family history of Parkinson's disease, pesticide exposure. Recently, earlier this year, there was a article that showed that those that live near golf courses were a higher incidence of developing Parkinson's, and that's also thought to be due to cumulative kind of pesticide exposure as well. And as I mentioned earlier, Parkinson's has those little inclusion bodies, what we call the Lewy bodies, when we look at the slides under the microscope. And when we break down those Lewy bodies further, we have found out that probably the reason that those accumulations grow there is due to this clumping together of this protein called alpha-synuclein. And so what we learned is that those things aggregate, those proteins clump together, aggregate, and they propagate, and they become misfolded, and they lead to further propagation of this misfolded protein. And that's what causes the cell dysfunction in those pigmented cells of the midbrain, which cause loss of dopamine, and then result in Parkinsonian features. These aggregation of the alpha-synuclein leads to mitochondrial dysfunction in these cells, and then leads to selective loss of dopamine producing cells in the midbrain of the brain. And then this in turn leads to the symptom manifestation of Parkinson's disease. Now, of course, it's kind of chicken or egg question as to like whether the protein aggregation is more of a cause for causing Parkinson's, or more of a symptom, a byproduct of Parkinson's disease, and whether there's just certain individuals that are more prone to develop that misfolded protein than others. Some have hypothesized that the abnormal protein kind of starts and gets introduced into the nervous system through either pathogenic exposure through the nose or the GI tract, and then it starts to aggregate in the brainstem here, and then spreads rostally up the brainstem, and then up into the cortex, into the surface of the brain. So that's what's known as this Brock hypothesis, where it's thought that this probably caudal to rostral spread of the abnormal protein leads to the stages of a different symptom manifestation in Parkinson's disease. Others have postulated even further that there may be a more gut to brain connection with Parkinson's and other neurodegenerative diseases as well, where pathogenic exposure in the gut may then lead to that propagation of that abnormal protein up the vagal nerve and then up to the brainstem. So that's what this slide shows here. There's people that have proposed that there may be neuroinflammation in the gut that could be due to the dysbiosis or disruption of the normal microbiome of the gut, and then that causes the abnormal protein, the alpha-synuclein, to deposit in the enteric nervous system of the gut. And then there's a long nerve called the vagus nerve that connects the brainstem to the visceral. And people have proposed that abnormal alpha-synuclein propagates up the nerve, up the vagal nerve, and into the brainstem, and then that's what causes stress, oxidative stress there, and leads to the cell loss of those dopamine-producing cells. And this has been shown that, like, if you cut the vagal nerve, that could potentially prevent the propagation of the abnormal protein. But that's been shown in various animal models of the disease. Now, ultimately, we are kind of all familiar with this, but just to go over it again, what are the main motor features of Parkinson's disease? The main features are resting type tremor, rigidity or stiffness, akinesia or bradykinesia, like slowness of movement, and then, of course, the gait and postural disturbances, so shuffling type gait, propensity for falls, imbalance. So those are the main motor or physical manifestations by which we define Parkinson's disease. But lately, there's been more attention and certainly more research that has been looking at the more non-motor features or non-physical symptoms of Parkinson's disease. And these are just some of the ones listed here, broken down by different categories. So there can be sensory disturbances. So sometimes there's kind of non-specific type symptoms like non-specific pain, fatigue, changes in weight loss. There can be disruption of smell, loss of sense of smell, or what we call hypotonia, weakened sense of smell, or a total loss of sense of smell. And oftentimes some of these symptoms even occur even decades in advance or many years in advance of the symptoms becoming to prominence. Other non-motor symptoms include sleep disturbances. So oftentimes REM sleep behavior disorder can be seen in Parkinson's patients, and also sometimes even years in advance before physical symptoms become apparent. So these are kind of like the vivid dreams that patients with Parkinson's often experience, acting out of dreams during sleep, punching, kicking, talking during sleep. Other sleep disturbances include like just trouble getting to sleep, staying asleep, restless legs, moving legs at night during sleep without being aware, sleepiness during the daytime. There can be mood disturbances associated with Parkinson's. Those are another non-motor type symptoms associated with Parkinson's. And so this can be depression, anxiety, lack of motivation, apathy, as well as hallucinations, delusions, paranoia. And then what we're going to talk about a little bit later are the common autonomic non-motor symptoms of Parkinson's. And so these are GI disturbances like constipation, gastroparesis, urinary disturbances, namely frequency, urgency of urination, or what we call overactive bladder symptoms, thermoregulatory dysfunction, that typically leads to like sensitivity to extremes in temperature, so cold, heat sensitivity, excessive sweating, and then orthostatic hypotension, which is a big symptom in Parkinson's and Parkinsonian conditions, which we'll describe a little bit further. So although we think of Parkinson's as mainly being a dysfunction of dopamine, and it is, it's important to recognize that there's other neurotransmitters, neurochemicals that are involved as well, namely acetylcholine, norepinephrine, and serotonin, and all of these, the disruption of that normal homeostatic balance of these neurotransmitters it is what leads to symptom manifestation. So in the case of the motor symptoms, mainly that's due to dopamine. In the case of some of these non-motor symptoms, that involves some of these other neurotransmitters as well. In general, most patients with Parkinson's don't start to manifest motor symptoms until there's already significant cell loss of the dopamine producing cells, and that's what this graph tries to depict. So generally, most people are diagnosed after there's already 50 to 70% loss of the dopamine producing cells. And then this graph is also showing that in general, like as the dopamine cells that are being lost over time continues to decline, that the amount of dopamine cells in the brain, then there's an increase in symptoms, not only the motor symptoms, which is the red line. So this is motor symptoms without treatment, motor symptoms with treatment there, and then also the non-motor symptoms, which is the green bar. As you can see, the non-motor symptoms and the motor symptoms both rise as there continues to be dopamine degradation, dopamine decline. And I just put this slide here just to kind of review briefly all the main treatments for Parkinson's. These are more geared towards the motor manifestations of Parkinson's. For the scope of today's talk, we won't be going over all these, but I just wanted to include these here. The main thing here is that I think the point here is that some of these medications, if not all of them, can sometimes contribute to some non-motor manifestations, namely orthostatic hypotension. A lot of these medications can contribute to lower blood pressure and propensity for dizziness. And then some of the anticholinergic medications can further exacerbate some of the non-motor GI symptoms. So some of these medications that are used for tremor that are anticholinergic in property, like arcogentin, those can have anticholinergic side effects, which can worsen constipation, urinary retention, dry mouth, those types of side effects. And then this is, of course, the levodopa structure that most patients with Parkinson's are familiar with the levodopa, the yellow tablets. Of course, as Tricia mentioned, the non-motor, there are non-pharmacological treatments that we also employ for Parkinson's, and this organization, PET4U, being one of those amongst some of the more national and regional organizations as well that do a good job of serving as a valuable resource for our Parkinson's community. Now, getting to the crux of today's talk is the common autonomic symptoms of Parkinson's, which we kind of touched on before, but we're going to focus on in particular constipation, gastroparesis, overactive bladder symptoms, neurogenic orthostatic hypotension, sialorrhea or drooling, and then thermoregulatory dysfunction, which is usually manifestation of like sweating, abnormal sweating, heat intolerance, sometimes cold intolerance as well. So constipation, probably one of the more prevalent non-motor autonomic symptoms in Parkinson's disease. About over 80% or over 60% rather of patients with Parkinson's experience some degree of constipation, and usually chronic type constipation, like something that occurs on a regular basis. Typically, the treatments for constipation, what we generally advocate for is hydrating, exercising. That helps with the bowel movement regulation. It's also important to try to minimize any exposure to medications that worsen constipation. So as I was touching upon earlier, anticholinergic medications like Artane or Cogentin, while they can be effective for tremor control, they also come at the expense of possibly causing or exacerbating some of the non-motor symptoms, including constipation. Antacids can also exacerbate constipation. Narcotics, so certain pain medications, particularly narcotic analgesic type medications, can worsen constipation. Iron supplements can also cause constipation. So if possible, trying to minimize these exposure to these, especially chronic exposure to these, particularly constipation is a prominent issue. One popular recipe that is used to help manage constipation is using 1 cup of Miller's unprocessed wheat, basically a bran formula, and then mixing it with applesauce and prune juice. and then refrigerating this and using 1 or 2 tablespoons on a daily basis and titrating that towards trying to have a bowel movement every day or every other day. Probiotics can also be helpful for gut health and for helping with alleviate constipation type symptoms. And then, of course, dietary fibers. Generally, we would advocate patients have a diet rich with prunes, bran, fruits, and vegetables to get the necessary dietary fiber to help with management of constipation as well. Some of the medication options that can be used for management of constipation include osmotic laxatives. One popular one, Lax or polyethylene glycol. This can be taken even on like a daily basis in a safe manner. Once again, on an as needed daily basis, but up to daily, to help regulate bowel movements and ideally aiming for a bowel movement every day or every other day. Magnesium citrate is another laxative that can be used. Stool softeners, generally we would want to use these just on a short-term basis and not like on a daily chronic basis. Those are medications like Docosate, Colace, milk of magnesia can also be used. But that, once again, generally we wouldn't want to be doing that on a daily basis, but maybe just short-term use until desired results are achieved. Stimulant laxatives also don't want to use on a chronic daily basis, but short-term use, they can be effective for helping move things along. And then enemas generally used when used in appropriate fashion can also be helpful for moving things along, but these aren't things that we would want to use on a daily consistent type basis because some of that can then cause dependency on from the gut to be more reliant on these things. And then particularly amongst the GI folks, the GI specialists, there are newer medications or relatively newer medications that have been used for what's called chronic idiopathic constipation, but can also be used for Parkinson's related constipation. And these are some of the medications that have come to market over the past 10 years or so. And they include Linzess, Amitiza, Trulance, and Motegrity. And those can also be very effective and be used on a daily basis to help as like a maintenance therapy for having bowel movements for those that have chronic constipation. And then, of course, getting evaluated by a GI doctor would be important to make sure that there isn't any other issues with the GI tract and that would structurally or otherwise that would cause slow transit or constipation. And so typically a GI specialist may want to make sure everyone that is experiencing these types of symptoms has their necessary endoscopies just to rule out any other pathology that would be relevant. Another prevalent GI symptom, non-motor symptom, autonomic symptom of Parkinson's is gastroparesis. And basically this is just describing like the upper GI tract being slow, whereas constipation is more kind of the lower GI tract. This is more like delayed gastric emptying from the upper GI tract. And oftentimes the symptoms that are associated with this would be like nausea, potentially vomiting, feeling bloated, abdominal pain or cramping, having early satiety, feeling a sense of fullness kind of prematurely, decreased appetite, weight loss, all can be associated with gastroparesis type symptoms. Once again, GI evaluation important to get the necessary studies to evaluate for this. Namely, that would entail getting a gastric emptying study and potentially doing an upper endoscopy to evaluate the gastric motility and whether it's functioning properly or if the peristalsis is the muscle contractions are slower than normal. There are some treatments that are what we call prokinetic agents. So these are medications that stimulate the contraction of the upper GI tract and can help move things and make things a little bit more quicker. So actually, there's an antibiotic, erythromycin, that can be used for prokinetic properties. Domperidone is another medication that can be used to help stimulate the upper GI tract, but it is not available readily in the US. Most often it would have to come from like a Canadian pharmacy because there can be some cardiac side effects that are associated with chronic use, but more typically at like very high dosages. And then there are now some newer medications as well that are helpful for stimulating or the upper GI tract, and these are Motegrity that we saw in the previous slide. Both can help with both constipation as well as with gastroparesis, and nizatidine is another medication that works on histamine receptors that can also serve as a prokinetic agent. The one prokinetic agent that we wouldn't want to use with Parkinson's disease is Reglan or metoclopramide. And the reason being is that this medication, while it can help stimulate the upper GI tract and stimulate the gut, it does block dopamine receptors in the brain. So it would further exacerbate a condition where there's already dopamine deficiency. It would block dopamine in the brain and worsen Parkinson's physical symptoms. So we wouldn't want to use that one. Even though it is conventionally used as a prokinetic agent to help with gastroparesis symptoms, but just not a good agent to use with gastroparesis, specifically in Parkinson's. Now, moving on to overactive, these are also very prevalent. Parkinson's patients, oftentimes this is described as patients having very frequent urination or having urgency of urination where they have to get to the restroom right away, or outright incontinence. Typically, we would want to evaluate this through a urologist doing urodynamic studies where they evaluate the bladder function to make sure, like in the case of males with these types of symptoms, making sure they're not prostate related, or in the case of females, making sure they're not like related to any potential gynecological surgeries or child rearing in the past. And in the absence of any of those other pathologies, then if there was no structural process like enlarged prostate, then the symptoms can be attributed to overactive bladder. And there are now quite a few treatments for overactive bladder symptoms. These are just some of the treatments that I listed here. So some of the medication options are Myrbetriq, Gemtesa, Trospium, Botox injections. So Botox can actually be injected into the bladder wall, and that can help with relaxing the overactive contractility of the bladder wall, causing overactive bladder symptoms. There's other medications like Vesicare or sulfenicin, tolterodine, darfenicin, and Tobias that can also be used for overactive bladder symptoms. One common one that often gets prescribed but may not be the best one to use in Parkinson's patients is oxybutynin. And the reason being, once again, this is an anticholinergic medication that crosses the blood-brain barrier. So while it is effective for controlling the overactive, the spasming of the bladder muscle, but the caveat being is that it crosses the blood-brain barrier, and then it can cause anticholinergic side effects in the brain, which typically manifests with worsening of constipation, can cause dry mouth, dry eyes, blurred vision, and then cognitive blunting by crossing the blood-brain barrier and affecting the acetylcholine in the brain. And then there's now also different non-medication techniques for helping with overactive bladder symptoms. And one non-invasive technique is what we call PTNS, or percutaneous tibial nerve stimulation. Oftentimes this can be done through a urologist's office in patients that have tried some of the medications above and didn't necessarily have the best results, or if they couldn't tolerate medications, or as an adjunct to those that are receiving medications. And basically this involves stimulating the tibial nerve down in the leg, and it provides feedback up to the sacral plexus and to the sacral nerve, which mediates bladder function and can help modulate the activity of the sacral nerve to help it so that it's not so overactive or overstimulated and causing the premature bladder contractions that lead to overactive bladder symptoms. And then there's also outright sacral nerve neuromodulation. So just like in Parkinson's disease, there's a treatment called deep brain stimulation where there's electrical stimulation delivered to the brain to help mitigate Parkinson's physical symptoms. There's also a stimulator for the sacral nerve that can help modulate the activity of the sacral nerve, and that can help with overactive bladder symptoms as well. Once again, this would kind of be evaluated through a urologist to see if someone with overactive bladder symptoms was a candidate for these particular stimulator type interventions. And now moving on to neurogenic orthostatic hypotension, this is a big symptom, a big non-motor symptom in Parkinson's disease. Trisha is also going to go over a little bit about the non-medication strategies of dealing with neurogenic orthostatic hypotension. But I just wanted to kind of go over what it's defined as and some of the treatments for it. Basically, neurogenic orthostatic hypotension is like a drop in blood pressure. This is the top number, the systolic blood pressure. Typically would drop by more than 20 points from sitting to standing or changing position, or the bottom number, the diastolic blood pressure, would drop by more than 10 points, once again, with a change in position. Typically, we ask patients to measure the blood pressure in both the sitting position and then standing up and waiting 3 minutes and then retaking it then to see if that holds true, if there's a drop in either the top number by more than 20 points or the bottom number by more than 10 points. And if there is one of those parameters being met, then that would satisfy criteria for neurogenic orthostatic hypotension. And the reason this occurs, normally whenever any of us stand up, there's a trigger in what we call the baroreceptor in your carotid arteries that triggers a sense and decrease of blood pressure, and then triggers the brainstem to release more norepinephrine to cause vasoconstriction of your vessels, to then allow for higher blood pressure to compensate for the low blood pressure that it normally occurs from shifting position. But in Parkinson's patients, because of the autonomic dysfunction that is related to the alpha-synuclein pathology getting deposited into the peripheral nerves, this receptor reflex gets impaired, and so there's less vasoconstriction of the blood vessels in response to changing position, and as a result, you don't get the normal compensatory rise, the normal compensatory release of norepinephrine to constrict the blood vessels and to allow for the appropriate response to drop in blood pressure from going from sitting to standing. And so this can manifest with symptoms of dizziness, lightheadedness, feeling faint or outright fainting. Oftentimes this can also be manifested as blurred vision or sense of just malaise, fatigue, weakness with changes in position. Sometimes people can get what's called like coat hanger headaches, where they get pain in the back of the head, in the back of the neck, and over the shoulder blades or up in the traps on both sides. And that's also characteristic of low pressure type headaches or orthostatic type headaches from changing position. Obviously, we don't want this happening because it can lead to fainting, risk for falls, head trauma, fractures, none of which are good things to happen. So as best as possible, we would try to minimize the manifestation of orthostatic hypotension symptoms. And so there are some treatments, both non-medication and medication, that can be utilized for managing orthostatic hypertension. So typically we would want to be very, cautious when changing positions for people that are experiencing orthostatic hypertension. The other thing is eating smaller meals, because whenever you have a large meal, particularly a large carbohydrate rich meal, blood flow gets diverted to the gut, and then there's less perfusion going upstairs, so to speak, when they're in response to a change in position. We'd also want to ensure making sure everyone's hydrated who's experiencing orthostatic hypotension. So they can't emphasize that enough. Making sure there's adequate fluid intake, and particularly increasing or supplementing salt if there's no cardiac contraindications, namely like conditions like CHF, congestive heart failure. Then liberalizing salt in diet to increase intravascular volume in the vessels, and to help with augmenting blood pressure in response to positional changes. certain, electrolyte rich solutions can be used, V8 juice, Gatorade, those things are useful as well. Compression stockings can be employed to help, once again, increase venous return that can pull in the from gravity in the legs and trying to increase the return of venous blood flow to the circulation to then allow for augmentation of blood pressure as well. The other important thing is to try to reduce any blood pressure lowering medications. Obviously, this may not always be feasible because sometimes people have labile blood pressure where they both have low blood pressure as well as high blood pressure. But if possible, if they're on like a medication for blood pressure lowering for hypertension and have less of a need for it now, then trying to wean off of those medications in conjunction with working with a patient's primary doctor or cardiologist or whoever had been managing the blood pressure medications. It's also important to realize that there's medications that we may not think of as having low blood pressure lowering effects, but certain medications for enlarged prostate or ED type medications for erectile dysfunction can also have blood pressure lowering effect. So trying to adjust those or wean off of those in patients that are experiencing orthostatic hypotension will be advisable. As well, certain antidepressants can also have a blood pressure lowering effect. So trying to wean those if possible. And then there are medications that we utilize to augment blood pressure, and these are some of the main ones here. Midodrine, Florinef or fludrocortisone, Droxidopa, or the brand name Northera, and then less efficacious in my opinion, but still another option is Mestinon or pyridostigmine. All of those medications can help augment, raise blood pressure in those that have that orthostatic drop in blood pressure. So these are some of both the medications as well as non-medication strategies for dealing with orthostatic hypotension. Now moving on to sialorrhea or drooling. This is another autonomic symptom of Parkinson's disease. Oftentimes patients with Parkinson's experience a lot of drooling. Either they are wetting the pillow at night from the drooling or experiencing outright drooling from during the daytime as well. A lot of this is also because there's slowness, stiffness of the swallowing muscles and less the rate of swallowing is decreased, so that causes the saliva to pool and come out of the mouth. But there are strategies for dealing with drooling as well. Some of the non-medication strategies for dealing with drooling would be chewing like sugar-free gum to force swallowing of the saliva by stimulating the chewing motion and the swallowing mechanism. And then there are medications that can be used as well. So some of the common medications, Robenal, atropine drops can also be placed under the tongue and can help with mitigating drooling. Scopolamine patch can be applied for its anticholinergic side effects, which can help mitigate drooling. And then Botox injections can also be utilized for helping to decrease saliva production and thereby decrease drooling. So oftentimes these are little injections that are done on the side of the cheek and into the parotid gland, which is one of the saliva producing glands here, and then also into the submandibular gland just underneath the chin or the angle of the jaw rather. And that can be a very effective tool as well for decreasing drooling. Some of the issues with the medication options are that they can cause anticholinergic side effects. So why they may help with drooling, they can exacerbate constipation or cause dry mouth, or excessive work too well and may cause dry mouth, or cause like dry eyes or other anticholinergic side effects. Some of them can cross the blood-brain barrier and cause cognitive blunting or confusion as well. So those are some of the limitations of the medication options. And then lastly, just wanted to touch briefly on thermoregulatory dysfunction in Parkinson's disease. Oftentimes, I have patients that come in and they say that, they have sensitivity to extremes in temperature, either, especially in their extremities, their distal extremities in their hands and feet, toes, or they have issues with abnormal sweating, whereas normally the other folks wouldn't sweat in those types of circumstances. They have very bothersome sweating. Um, and typically the treatments for this are mostly kind of behavioral and just being mindful of being of the circumstances and trying to avoid extremes in temperatures, staying hydrated once again, using cooling devices, fans when it's hot or warm out, and then dressing appropriately when it's cold, bundling up, wearing extra socks to help with distal coldness of the extremities. There are a few medication options that can be helpful as well. So topical glycopyrrolate can be helpful for decreasing sweating. Drysol, which is another topical agent that can be useful for helping to decrease sweating. And then Botox injections, again, can be used for hyperhidrosis or excessive sweating, particularly if it's in the axilla or the armpit area, or the palms. Those are two of the FDA approved sites for Botox for hyperhidrosis for abnormal sweating. And I will now hand it over to Trisha, who is going to talk a little bit more about the non-pharmacological, non-medication management of one of the big non-motor symptoms, which is orthostatic hypotension.
Okay, thank you, Dr. Vora. That was excellent. We appreciate all that information. If you could stop screen sharing, I'll go ahead and share my screen. Okay, there we go. I know you guys have questions for Dr. Vora. There will be plenty of time to ask questions. I'm going to go ahead and just take about 5 minutes to go through this. Are you guys, Dr. Vora, are you seeing the actual presentation or oh, actually,
I can see your screen.
how about now? Are you seeing the presentation or the notes?
Oh yeah, I think it's your slide, your presenter's view.
How about there? Is that better?
Yeah.
Okay, perfect. All righty. So one of my roles, in addition to being a instructor and member of the board at Pep4U, is I'm a neurologic board certified in physical therapy for neurologic individuals. And I also am a clinical associate professor at Chapman University, which is where I teach lots of doctor of physical therapy students about how to manage and working for it with people with neurologic conditions, specifically those with a lot of them specifically with Parkinson's disease. We have some different activities for that as well. One of the things that commonly occurs, as Dr. Vora was saying, is this drop in blood pressure. So we're going to talk a little bit about some ways you can manage it, not related to medication. So just to review, he already commented these, but that feeling of almost fainting, dizziness, heaviness in the head, fogginess, blurred vision, that neck and back shoulder pain that he mentioned are common signs if you have it. This slide, goes over exactly what he already said and how you're screened for having this. You can do this screening on your own if you're safe to do so, if you're not one that passes out with this problem, but you lie on your back for a while, about 3 to 5 minutes, and they take your blood pressure, and then we have you stand up and we wait 3 minutes, we take it again. This screening should be done, every 3 to 4 months, just to make certain that you're not becoming orthostatic when you're standing. But this is very simple to do and often done in the clinic. Things that, just so you know, things that tend to make this condition worse. So if you do experience those drop in blood pressures, one of the number one that as a physical therapist, I like to try to fight is that prolonged bed rest. We want to get people mobile. Laying around and sitting around actually makes it worse. So we want to get them mobile, but in a safe manner. The other thing is not enough fluid, making sure you're getting enough water and other fluids throughout the day. Using alcohol. Alcohol is actually a dehydrating type of fluid that we take in. So avoiding the use of alcohol. Exercise is one way. Activity is one way we help work on this, but extreme exercise can also cause our blood pressure to drop. So that has to be modulated a little bit, but exercise isn't bad. It just has to be regulated. Exposure to heat, having a fever will often tend to make this worse. Being anemic will tend to make it worse. Hyperventilating after eating a meal, and Dr. Vora talked about how you should eat smaller meals throughout the day, because when you have a big meal, the blood rushes to your stomach and is working hard to digest it, and it's not being perfused up to your brain. So it's really helpful to have those smaller meals, or for sure. And then some different medications, which he already touched on in his area expertise, so I'm not going to go further into that, can also make it worse. So what can you do to help it? One thing you can do at home is, if you tend to experience this, is to have your bed. You don't have to have like a bed that bends and the head of the bed raises, but you can just even take a regular bed and put the head of the bed up on some of the blocks that are made for that, which you can buy at Walmart and different places and order them online. And then maybe just elevate it 10 to 20 degrees. It helps keep the blood for your body used to having your head up a little bit. And then you want to do what's called postural changes slowly. Dr. Vora talked about that. When you stand up or sit up, you don't want to go rush and then get right up to standing. Take your time, wait 20, 30 minutes, take a 20 or 30 seconds, excuse me. Take a pause before you get up and walk. Or if you stand up, take a pause before you get walking, maybe, and march in place a little bit before you walk away from a chair. Prolonged standing is something that you want to try to avoid. So if you know there's going to be a long line somewhere, maybe bring something to sit down if you can. One thing that I want to talk about is Valsalva-like maneuvers. That's like bearing down to go to the bathroom. Those kind, holding your breath to do things, those can stimulate the vagus nerve, which can cause your body to lower the blood pressure. So you want to try to avoid that kind of activity. And when you can, rather than stand to shower, you might want to have a chair in the shower that you can sit on. And for men who get lightheaded, they may want to sit down to urinate versus stand to urinate to help with that. What about if you have a trouble with this lowering blood pressure? What are some things you feel? You're starting to feel a little lightheaded. What can you do? Walking and stepping in place. You can do this sitting or standing. Crossing your legs, it kind of helps push the blood back up towards the brain, which is what we're hoping to do. Tensing your lower body muscles, like your buttocks and your ankles and your knees, tensing those muscles up. Sometimes if you're getting really lightheaded, bending forward can kind of use abdominal pressure to push up the blood back up towards the brain. Even things like clenching your fists can be really helpful because it helps pump the blood up. Our muscles is what pump our blood up towards our brain, is one of the things. So using and contracting those muscles at the time can help with that. Dr. Vora talked about fluid intake, and so did I previously. This is just a guideline, and there's been, they looked at it, and just increasing 500 milliliters, which isn't that much, actually raised the blood pressure within 30 to 90 minutes. So it can be relatively quick that it can help with that. He already talked about salt intake, something called abdominal binders. Abdominal binders are just something that goes around the lower abdomen. You put them on, they just Velcro on. They help keep that tone of the muscle, act as the tone of the muscle to help keep the circulation up towards the brain. And so, compression socks and stockings, sometimes people need them to go further up the leg, but usually down on the calf can be very helpful. Sometimes people that have it really severe, we've had to use both the abdominal binders and the stockings. I've even had a patient that it was so severe that we had to do those two things, and we had to ACE wrap on top of that their legs. But the point was, we wanted to get their blood pressure up so they could be mobile and not sit all day. And that is it. I just wanted to highlight some of those specific activities that you could do to help with your blood pressure if you had an issue with that. And now I want to open it up to ask Dr. Vora any questions, or myself, but primarily for Dr. Vora. I know you guys have questions that you are burning to ask. If you would like to just unmute and ask, that's fine. Or if you want to raise your hand, I'll be watching for that as well. I'm going to take myself off the spotlight. And I've got, does anyone have any questions? Let me see here if I can view. I'm going to remove this spotlight here so that we can see everyone. Oh, there's someone that has a question. Jan has her hand up. Jan, go ahead and
Um,
ask your question of Dr.
okay,
Vora.
I'm wondering in terms of gastrointestinal issues, is it beneficial to see a gastroenterologist who is more expert in motility?
There you go. You're
Just had to unmute myself. No, yeah, I think that's a great question. I mean, yeah, I think in general, I mean, all in theory, all gastroenterologists should be adequately trained in terms of addressing GI issues with Parkinson's. But yeah, there may be certain gastroenterologists that market themselves as more motility type experts, and if that's the case, if you have access to one, I think that would certainly be advantageous to get evaluated by one.
Great. Thank you for that. Okay, I'm going to
Hi.
remove the spotlight. So who else has a question? Oh, it looks like Melvin's screen has a question. We'll unmute you. Okay, go ahead. Oh, we still can't hear you. Can you try unmuting yourself? Oh, I think you just muted. Try hitting that unmute again, Melvin's, and now speak really loudly.
I think
I'm
there's
sorry. Oh, there we go. Go ahead. Nope, we're not hearing you. I'm so sorry. Keep working on that. And I'm going to go to, let me see who else had a question. Hari has a question. Hari, do you want to go ahead and speak?
I want to ask you about balance issues. My problem is, can you see me? You're seeing my head, now the face. So my, very uh, important and central problem is balance. I'm very afraid of falling down. Okay. I have fallen down 3 times in the last 3 years, and I'm very sensitive to it. So that makes me nervous also. So it becomes worse. So how do you think we should handle it?
Oh,
Dr.
I'm sorry. Was that directed towards both of us or Trisha or myself?
Anyone of
Why don't
us,
you go ahead, Dr.
anyone of
Bora? Hari
you
hears from me all the
can.
time.
Yeah.
Oh,
Good.
okay. No, I mean, I think it's an important question. Without getting into any one individual's like specific circumstances, I think in generality, I mean, imbalance can be both motor and non-motor, inputs that can influence one's sense of balance with Parkinson's disease. So there can be the physical manifestations of Parkinson's that can cause the imbalance. So shuffling, people that have freezing of gait, or just postural instability in general. So that would involve working with, the treating physician to work on optimizing medication strategies for optimizing the physical symptoms so that there's less shuffling, freezing, and potential postural instability. And then also looking at what non-motor symptoms are contributing to one's sense of imbalance. So namely, if there is orthostatic hypotension, evaluating for that, testing for that, and then treating that if it is present, to minimize orthostatic symptoms in an effort to also improve balance and less propensity for falls. Particularly if there's like manifestations of orthostatic hypotension, like dizziness, that's affecting balance. Oftentimes in Parkinson's patients, I mean, it's a combination of both things, the motor manifestations from physical symptoms of Parkinson's, as well as the non-motor manifestations like orthostatic hypotension that are both influencing one's sense of balance.
And I'm just going to add to that also, your posture makes a big difference. So if we're bent over, we're going to be closer to our edge of our balance limits. So we're going to be more likely to fall. So I really recommend that people get evaluated for their balance specifically by a professional like a physical therapist that knows how to assess balance individually for you and takes you through some measures to see what it is. Is it the non-motor symptoms, is there are postural exercises and balance exercises that can help you. So I encourage that as well. So I'm going to do that. We're going to go back and thank you, Hari,
Okay.
for the question.
Thank you.
We're going to go back to the Melvin, I believe it was. Let's see, where are you? Melvin, let's see if we can hear you. We still can't hear you. Would you like to put your message in the chat? Question in the chat?
Looks like someone asked if they would
Would
recommend
you?
the Exelon patch. Was that in reference to any specific non-motor symptom, or I mean, Exelon patch more conventionally is used for cognitive symptoms associated with Parkinson's disease, not necessarily with the autonomic symptoms of Parkinson's, but Exelon patch is a useful tool for memory cognitive symptoms in Parkinson's disease, and then some of those medications that are conventionally used for memory, like donepezil, Aricept, Exelon, or rivastigmine, can be useful. There is some literature that suggested that it can be helpful for reducing falls in Parkinson's disease and helping with balance. So potentially it can be useful for that.
And they said for orthostatic hypotension.
No, yeah, it's not something that I've employed in that manner for orthostatic hypotension.
Great, thank you. Okay, let's see if there is anyone else that has. Erwin has a question. I can see him raising his hand. If I'm not getting to you, I have different screens, so I will try to get to everyone. Erwin, do you want to unmute? Or I can try to unmute you.
And
There you go. Go ahead, Erwin.
yeah, this talk has been very helpful in learning about the physical impacts of Parkinson's disease. But I've seen in family members and others who've had Parkinson's, the mental part is not been discussed here today. The depression, the anxiety, a lot of things having to do with your behavior that are derivative from having a Parkinson's condition. So could you speak to that issue?
No, yeah, I totally agree. I mean, I think it was just beyond the scope of our talk. We wanted to limit our talk to something that can be discussed within the time frame that we have allotted. But yeah, certainly the cognitive mental aspects are that could be a talk into it of itself. But yeah, a very valid point. I mean, we don't mean to minimize or discount those symptoms. It would just be like it would probably take like an hour-long talk on its own just to discuss those and the treatments for the cognitive symptoms, as well as the potential other symptoms that can be associated with mood changes or hallucinations, psychosis of Parkinson's disease. All of those, there's different treatments for those, and yeah, certainly that would probably be a good topic for the next round of the PD Education Hour.
Could you
Yeah,
just
thank you.
talk a
Well,
little bit about depression without doing an hour-long discussion?
Yeah, I mean, depression, mood symptoms, certainly very prevalent, very common with Parkinson's disease and neurodegenerative diseases in general. Treatments are typically the same that we would use conventionally for depression of non-Parkinsonian, like not associated with Parkinsonian conditions. So oftentimes we employ SSRIs, so medications like Lexapro, sertraline, Zoloft, or other antidepressants, SNRIs, tricyclic antidepressants to some extent as well, for treating those mood symptoms, working with ancillary services as well, like a psychotherapist, counselor, therapist, psychiatrist, as well to help address mood symptoms. But yeah, once again, very prevalent with Parkinson's.
thank you, Erwin, for the question. There's a question in the chat that I think is really important that maybe you could answer. What do you think of increasing my carbidopa, levodopa meds during a very active day, or just staying with what is prescribed? Can I take too much?
Yeah, that's a good question. I mean, ultimately, everyone's Parkinson's regimen is individualized to and tailored to their needs, and ideally, one would be working with whoever their prescribing provider is. Because I hesitate to make like a blanket statement without knowing someone's medical background and other medical conditions that can influence like their dopaminergic need within a day. But in general, like, yes, certainly with increased activity, there may be kind of more metabolic use of dopamine. And so potentially it may be advantageous during those times to take a little bit more or have like a PRN or as needed dose of levodopa or whatever dopamine type medication that someone is being prescribed to use during those times. But any discussion about using that in that fashion or increasing meds or using like as needed probably would be best, to be discussed with whoever the prescribing provider physician is, just to make sure that there isn't any specific contraindications or things to monitor for that would be of concern. Like, once again, someone who's experiencing, just for example, like a very prominent issue with orthostatic hypotension. And when they take more medications, it worsens orthostatic hypotension. That may not be like an optimal strategy for them to take too much or take an extra dose. And then as to the question of taking too much, once again, that's dependent on the individual, because some patients may be more sensitive than others in terms of the side effect profile of the medications and what they experience. For some people, half a dose or one dose of cinnamon carbidopa levodopa, they may not be able to tolerate. Whereas other patients of mine, I have them that that some people are taking upwards of 5 tablets in a single dose administration and tolerating that fine. So it varies from individual to individual.
Well, thank you for that eloquent answer. I know that we are out of time, but I wanted to give Melvin one more and his lovely person with him one more chance to see if they could get their question out. I didn't see it in the chat. Oh, I'm sorry, we still can't hear you. So I apologize. We won't be able to get your question in. We're going to end for today. If I missed anyone's question, I'm so sorry, but I want to be respectful of Dr. Vora's time and all of your time, because we did say it was the hour period. I want to let all of you know, though, that these are recorded and they are posted. Give it a few days. This presentation will be posted on our pep4u.org website. And in fact, there is a topic that was covered on our last education a few months ago, where it was somebody talking, one of the caregivers said the mood symptoms and things like that. She has some good tips for caregivers and providers and families to deal with the emotional, social aspects. So you can go back and look at that. That is recorded and posted as well. On behalf of Dr. Vora and myself and all of the Pep4U support staff, Barbara and Gabby and David, who were behind the scenes helping to make this go smoothly, we want to thank all of them. And I want to thank all of you for your time. And just a final reminder that we would love if you are interested in helping us reach our $10,000 goal by Labor Day. If you're interested, go on our website. There is a link that you can donate any amount. $5 is not too small. We'll take anything. And we thank you so much for your time. And we're so glad you're able to do this, and no obligation to donate, just if you're so moved. Okay, we love having you, and we'll see you guys in a few months. Bye-bye.
Thank you.